To stop, I guess, because we got to get signed in again, right?
Yeah.
Then I have my.
That's Joan. What do you have? Are you in the next 2 sessions?
Yeah.
And then let me see that real quick. I don't have anything till bias, right?
Right.
Good.
And we have a break, and that's a food break.
Yes. Oh yeah, we're gonna have the popcorn and stuff again.
Good,
Everybody
good,
love
good.
that.
All right, so I've got to watch.
If everybody from outside could start making their way in, we'd like to get started.
So I got to go.
Whew, it got quiet all of a sudden. Who has not been scanned for this session? She's not sure if she was. So while we have people mingling in, those of you that are staying this evening who have not told me if you want fish or lasagna, can you please raise your hand or? Okay. Pardon me? Well, me too. Besides that, do you want fish or lasagna? Fish? You want fish? Yes, ma'am. Oh, I think it's baked cod. I could double check, but I'm pretty sure it's baked. Did you say fish? Fish or lasagna? Lasagna. Okay. Thank you. Marsha. I'm pretty sure it's baked, yes. Fish or lasagna?
Fish or lasagna? Fried fish, baked fish?
I believe it's baked cod.
Lasagna.
Okay.
There you go.
2 lasagnas? You don't want? All right. Who has not given me their order for tonight? What? Fish? Lasagna? 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 Yeah. We got yours. Fish? Okay. I got you. Fish. Fish or lasagna? Okay. It's baked cod. Okay. All right. You're welcome. Anyone else have to give me their order for tonight? Fish or lasagna? Fish or lasagna? Are you staying for this evening? Fish or lasagna? Stephanie, are you and Marla fish or lasagna? I can't remember. For this lasagna? Okay. Oh, that's right. That's right. Do I need anyone else's dinner order for this evening? That did not give it to me. Fish or lasagna? Let's see. 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 19, 21. Okay. Great. All right.
All right.
Also, I just want to let you all know that we're sorry for the delay in the lunches today, but when we had done a head count, we had only received so many vegetarian requests. So we apologize for those that had to wait for their vegetarian meal, which is one of the reasons why we're confirming our dinner for this evening. So thank you very much for your patience.
And don't forget to do your evaluation. That time is coming up for many of you. You must tear it out, sign it, and turn it into the registration table, please. Whether you want CMEs or not, please fill out your evaluation. That's the only way. Huh? Those people that are leaving today, though, we need your evaluation today on your way out the door. Please. We need your input. I have to admit, I've been evaluating us the entire time, and I've got notes all over my book to prove it. So we are not perfect, and we know that. All right. I'm back. to have a thought for the afternoon. Wisdom is not a product of schooling, but the lifelong attempt to acquire it. That kind of applies to some of us folks, right? We may not have the big MD or PhD behind our name, but you're experts in sickle cell. You are, okay? Let's not forget that. And what else do we want to say? Celebrate. Come on, help me. Celebrate life, lessen the pain. Thank you. All right, we're going to talk just a little bit about education and some general concepts around this whole idea of educating patients and ourselves, really. Okay, we've all been through some educational activities, right? Somewhere along the line, you've been through something, even if it was in kindergarten, okay? We've been through something. I don't want to offend you, but I want to make sure we all are aware that education and learning are not the same thing. Now, what does that mean to you? Are you saying, oh yeah, sure, Joan? Or are you saying, huh? You see what I'm trying to say? The education is the activity that is provided or done to do the learning, but the learning is the onus of the recipient of that activity. And as we go through this is going to become a little more evident. In the nature of learning, there's the 3 domains. Dr. Smith, I believe, mentioned this maybe Tuesday, I believe, is that there's the cognitive part, or the intellectual part, the knowledge part, okay? And believe it or not, that's the easiest to deal with. You know, you come in and you get told that your child has sickle cell disease. And you may have grown up where you didn't have any family members with it, or it was pretty far, you know, cousin maybe you don't really see, so you don't have a perception of that. So you're like, what? Our baby has what? So there's that educational activity. You know, it may be the physician, a nurse, maybe a neighbor or somebody else, which could be bad or good, all right? That one's pretty easy. You provide information, we absorb information, we gain knowledge, and our knowledge lifts. The affective domain, or better known as our emotions and our attitudes, whoa, this is what can be challenging, isn't it? We all have. And where do our attitudes come from? Experiences. What else did we talk about this morning? Our culture, our belief system, everything. And one thing we haven't mentioned a whole lot, but I think I've seen it on a couple slides, but I haven't said it, it's our spirituality. Not just necessarily your religious affiliation, that's important too, but the spirituality is very important to all of these discussions, isn't it? Some folks had put that on their values, wasn't it? Their faith was very important to them. All right, so attitudes and emotional, they're difficult to work with, and they are the hardest to change. I think some of us were talking about it at lunch, some of you were talking on a break. Dr. Smith, one of the hardest things to do is if you need a champion for your sickle cell program and you've got some attitudes to change out there, they are challenging. All right. Now the psychomotor I put on here just to round out that it is the 3rd domain that we do learning. And in sickle cell, it's not like we have a huge number of those. Certainly with nursing background, I spent a lot of time in nursing clinics teaching students how to, well, believe it or not, we used to teach making beds. That's not as important these days. But, you know, giving injections, talking with patients, you know, laboring, you know, understanding labor contractions and being aware of when the baby's ready to come, you know, and all that good stuff. So you teach all of that. And psychomotor are actually some of the easiest things. Now, have any of you ever tried to do something that requires psychomotor? Some of you bound to do something, right? Any of you do like yoga or do any physical activity? Some of you. I'm an ice skater. Well, talking about trying to learn now, believe it or not, ice skating is a psych thing as well as a motor skill, all right? It's huge. Can you imagine somebody tells you that you're going to jump up, you're on these, got these shoes on, they've got these skinny little blades, and you're going to go scooting down the ice, and then you're going to jump up, turn around, and land on the other leg, and you go, huh, you got to be kidding. I am not doing that, okay? But psychomotor can be very challenging, because imagine, I'm a real fan, and so, skating season is getting ready to open up, and I'll get all excited as, they go to, the different competitions, and it's amazing what these young people are doing these days. All right, so let's talk a little bit. Affective domain involves the attitudes and development of the value, the emotional aspect. Psychomotor sometimes can be some of the easiest. Psychomotor, though, we may actually, working with patients to take their hydroxyurea, could almost be a psychomotor. It certainly involves those others. But just you may have patients that may be struggling with just the actual fingering and counting out the pills and understanding that and actually taking them. I mean, that sometimes can be an issue, especially as some of our patients are aging. They may have, or what we said, may have cognitive impairment. All right? All of our education is seen through the lens of the learner. All right? What does that really mean? Well, that means that the folks that we're trying to educate, everything we do is through their lens, not ours. In many schools, in my day, it was all about the teacher. You go in, you did everything what the teacher wanted you to do. You got up, you sat down, you did whatever. What we're now learning, and we need to understand when we're doing patient education, is that everything we do is through the lens of that person. Probably the most important thing that we need to know, all of these are important, but if you really need it, you need to know where that patient is, and you need to meet them where they are. And I think we've mentioned that. I know Shirley did one day this week that we were here. We got to meet them at least halfway, don't we? And I know you guys already know that. We got to know a little bit about their belief system, their culture, their generation, and their ability to relate the information. And what we're learning in some of our sickle cell patients is the fact that there's been these silent, remember we talked about the silent strokes, or TIAs, okay? Transient ischemic, I don't forgot the, attacks, okay, TIAs. And so there's been some brain damage. And so you may be sitting there frustrated, beating your head up against the wall, and some of it may be a physical impairment. So you have to really relook at how to do your training. Now, didn't you love the hose and the banana and the thing? Wasn't that fantastic? Okay. That's the kind of stuff that we have to do to help explain things to our patients. Because we are not all the big scientists, and we not all have been through the formal education. So, all right. Thought. This is kind of our thought. Learning is what happens when what you thought would work doesn't. Well, I'm glad somebody chuckled. I thought that was chuckable. You know, we think we're doing what we got to do, and we just don't. We're just going to keep doing it that way because that's the way we've been taught, and that's the way we're going to do it. And it's only till we finally figure out, you know what? That didn't work. Let's step back, and maybe there's a better approach. All right. By the way, I didn't know where that came from. I just found it. I liked it. I stole it. All right. So now we're saying what the most important thing is about what this person knows and where they are in their particular world, right? So that first step is a thorough needs assessment of what does the patient want to know, what is the patient readiness level, what can we do to help motivate. Remember we said we can't really make them motivate, but we can do things like do motivational interviewing, right? We can approach things to where they may want to be motivated to learn about something. What is our priority is the provider, we're going to have goals and priorities, aren't we? Yes, we are. We have needs. We got needs because we need that patient to understand how to take their medicine. We need that patient to understand some of what's going on in a pain crisis. We need for them to know and understand how to do some things, right? We've got lots of needs, but that's our needs. So we have to figure out how our priorities and our needs match with the patient. Any of you heard of Maslow's hierarchy of needs? Okay, a lot of you. Good. Basic information, I think, in every social work, every nursing, every human services, whatever out there knows about Maslow's hierarchy of needs. So therefore, that we don't have to talk about it that much. But realizing that if your basic psychological needs are not being met, then education is going to be difficult to do, isn't it? So it's that basic, and many of you, I found out many of you are parents, and some of you that are parents are female parents, so you've gone through the birth process. And I know that you've learned in taking care of that newborn baby that that baby is never going to smile at you until you've met those basic needs. You know, clean my diaper, feed me, mama. Very basic. And then over time, that child grows and develops and learns. But we have to take care of those basic needs. I threw this in just out of, I just thought it was interesting, because we done touched on this, and it's interesting that I had thought even in doing this. In today's world of educating patients, we need to be somewhat aware of our generational differences, all right? Just the whole generation thing. All right, who in here is going to fess up that you may be a baby boomer? All right, there's a few hands. All right, I'm not all by myself. The Generation X now, is that 1960s, 1980s? Okay, all right. Oh, I got right many. How about the net generation? Uh-huh, that's what you call. Now, guess what? This was interesting. And yeah, I'm reading the newspaper the other weekend. I haven't had a chance to read newspaper a whole heck of a lot because we've been pretty busy. But it was a Sunday and I'm reading it, and lo and behold, here's this whole article about Gen Z. And I went, huh? I had not heard that. Have any of y'all heard about Gen Z? Okay, good. See, y'all are ahead of me. Anyway, I read the article, I was fascinated, I went, oh, I had just put this slide in, and I went, oh my gosh, I'm going to be embarrassed, I don't know about Gen Z. So luckily, you know, newspapers, they don't reference their material, so I'm sitting here going, well, I don't know whether this is real or not. So I very quickly Googled and tracked down some of the people they did quote, and sure enough, and I think it's the Pew organization that does a lot of this work that kind of looks at it, and just in the last few years, they've said, you know what? We need to do a new generation because the Gen Zs are different from the net generation. And they are different in that they have been born and raised with the internet. They don't know anything different. And they're very interactive. They expect interaction, and guess what? They expect to be a part of it. And then I go, any of y'all like, I love. So you think you can dance? Because I love watching those kids dance. And I think it's that other dance one, what is it, Dancing with the Stars, where the audience actually determines who wins the show. Well, that's a Gen Z thing. And that Gen Z folks expect to be involved in all of this, where us boomer babies, we're from the age where you walked in the classroom, the teacher told you what to do, when to do it, how to do it, and that was the way it was. So it's very different. So in looking at your patient population, now that we're beginning to have patients, we've got some that may very well be in the boomers. We certainly have a couple I know in our program because I know one of them. But there's a little different nuances as how they approach. Does anybody recognize that picture, by the way? It's an old manual typewriter. I had to put it on here to represent the baby boomers because this is what I grew up on, okay? I remember when it was exciting when I didn't have one until way later, but an electric typewriter. I thought that was coming of age. And now we have word processing and all this other good stuff. So anyway, just being somewhat aware of the different generations help us tell, and as we're going to get into a little bit about the education, may drive some of what we're doing. Have you not felt like we have done some of this, applied this to our training? What have we done? We've added in some technology, haven't we? When they first said, let's do a Mentimeter, I went, a what? All right, I had never heard of a Mentimeter. But then when they explained it, and these are some of our young folks here that have been working with us, then I went, oh, wait a minute, I was on a webinar where we did this. Oh, is that what that's called? Oh, that was pretty cool. Wasn't it pretty cool to actually get input, doing our clouds, answering some questions, seeing how the group did? And then I went, oh, well, yeah, I've been part of that. Oh, that is kind of neat. Okay. But for me as a baby boomer, I'm not necessarily going to think about that to start with. Okay, so I'm having to learn this stuff. But in approaching education of our patients, we need to kind of have a feel for where are they on this? Where are they on this? All right, learner-related barriers. Now, Shirley touched on this, and I'm going to expand a little bit about literacy. It is the degree to which individuals have the capacity to obtain, process, and understand basic health information and services needed to make appropriate health decisions. This is the definition from the Institute of Medicine report that came out a good while ago, I think 80s, early 90s, Dr. Smith, I can't remember. Okay. Low literacy is a major problem in our country. Health literacy, oh, there it is, there's it. All right. So, and kind of to relate this to what we're doing, is that literacy is our ability to do that. Health literacy relates to our health information, to make health decisions. So literacy is that typical, it's our ability to read, write, and arithmetic, 3 R's. Being able to understand basic numeric concepts, in other words, to be able to do math. Literacy influences people's ability to access information, use print information. How many of you use printed materials, brochures, etc. in your activities? Probably everybody, right? How many of you really use those yourself as a person? Maybe, okay? So we learn differently, we accept information differently. But if you're literate, you have the ability to use printed information to learn something. General literacy leads to some, but not all, skills to understand information and communicate. Where health literacy is just the applying that same information, but to the world of health. So like health literacy is influenced by the language we speak. I learned back a bunch of years ago when I was involved in a project having to do with perinatal depression. And we went out and did some focus groups with various cultural groups. And guess what we found out? And we had no way of knowing this. Some cultural groups did not even have the word depression in their vocabulary. So how in the world can you talk to a young mother, because I was talking about postpartum depression, about depression if in her language, even if I had an interpreter right there with me, I may not be able to get my message across. That's a challenge, isn't it? So years of school, I thought this was very important, do not correlate with health literacy. Have y'all found that to be true? Very much so, isn't it? And healthcare professionals, and here's the underline this, we have the burden to do something about it. We are the ones who need to do something about it, not the patient. Okay? 12% of U.S. adults have proficient health literacy. Turn that around. That means 9 out of 10 adults do not. So think about your patient population and apply that statistic. It may be kind of dismal. Because our patients have had lots of barriers and reasons why their health literacy may be affected, right? And so that's pretty. So the burden is on health professionals, And you know what? We cannot use that excuse. Well, you know, we just don't have the money to do this. There's a lot of things we can do within our practice lives to promote health literacy. So what are some of those things? And why is this important to us? Well, it is documented in the literature that folks who have low health literacy skip preventive services, don't see it as important, not important to them, they're not going to do it. They're less able to manage their chronic disease. Sickle cell is a chronic disease. They have less knowledge of their disease. Some of our patients now, that's not very true, is it? They're very, very, very knowledgeable. But overall, from the literature, we're talking about patients with hypertension and diabetes, and some of those have less knowledge. It'd be interesting to see that same survey applied to our sickle cell population. Do you know of?
Yeah, what we did in the inpatient unit of our hospital, I have 2 points on one thing.
Okay.
I'm going to make this point.
Oh, it's back. Can you bring it up? It's it's here. It was a snake. It would have bitten you. My mama would say.
Showing what we did.
Yes, thank you.
Is the battery dead?
Ah, there it is.
Joan, what we did in our hospital on the inpatient medicine service was we administered a simple reading test.
Mm-hmm.
It's mic just went out, the battery just went out.
Stand up. I know you can do it. Here, you want to use this?
We administered a simple reading test that has been linked to health literacy. It's called the REALM,
Okay.
Rapid something assessment of literacy in medicine. Here's an example of the question on the REALM. It's not about can you read. It's can you appropriately interpret and apply information. Here's an example. You are to take 2 tablets twice daily of a medication. How many total tablets should you take in a day? What do you think people said? They said 2. And they said it right back. They parroted it right back to you. Yeah, you said take 2 tablets twice daily. They parroted right back to what you just said. So that's about math and about application, not about reading a bottle. So that's an example of real, on the ground health literacy. And in that case, it's health numeracy for those who are word parsers. I'm looking at you. Word parsers out there. The second point I wanted to make is if it were all about reading, then we wouldn't have college educated people who are health illiterate. We do. And those are people, for example, who don't understand how to use the phone tree and what buttons to press to get where they need to get because they don't know the medical terminology to get to the right specialty, all those ologies, right? If you want endocrinology, press 7. Do you know that if you have diabetes, that's what you want? If you want somebody to deal with your priapism, what ology do you want? How many people know that and know to press that number? Yeah, okay. So the issue, yes.
One thing that I notice a lot when I do transition assessments with our patients that are transitioning to adult care, is I'll ask them why they go to a hematologist, and
99% of the time, they don't know what a hematologist is. They're just like, I go see Dr. Sizzler or I see Jennifer Newland, and that's all they know. Yeah. Yeah, so they don't even know what a hematologist is. So we're trying to start that earlier, but when I ask them that question, 9 times out of 10, they have no idea what I'm talking about.
If you put that paper in front of them, they could read the word hematology just fine. So it's not necessarily what we think. It's not just about being able to read. Now, physicians, unfortunately, make an assumption. Because you don't have my cultural baggage and know all the lingo in my circle of words, you can't read. They're projecting that onto the patient. Insulting, but unfortunately, that's happening. So when you talk about health literacy, you really have to step back. And as you said, it's not just about education, it's about all of the ologies, understanding it.
Right. Also, the literature does support that there's an increase in preventable hospitalizations and ED visits. And I'm going to go on because I think there's who's at risk. That's straightforward and out there. We all kind of know that. Now, I wanted to get to this slide. So how do you detect? Well, Shirley had a beautiful example earlier today. Would you read that to me? I forgot my glasses. That's a flag. Now, I say it all the time, and I hope I'm health literate, but it's because I truly am blind. My glasses, I have to have them. Okay, limited vocabulary. I'm sure we have some of our patients with limited. And guess what? Patients that do not ask questions. That doesn't mean that they know everything and understand everything. They'll sit there and shake their head and nod. Oh, yeah, thank you, nurse. Thank you, doctor. Okay. And they go out the door and they don't have a clue what just went on. They'll ask, if you do a survey question, like Dr. Smith just gave a beautiful example, they didn't know. Inability to do simple math. So some of these techniques are out there. So the benefits of health literacy, I think, we kind of know that. We can save money, we have better patient outcomes, we have improved communication, adherence to treatment, all those good things. I just wanted to mention about the internet, and we've talked at some of our lunch things. 84% of U.S. adults have internet access, and this is from the Pew Research Center in 2015. I'm sure that's gone up. And more people seek health information from the internet than ever before. Y'all agree with that? Yes, that's what people are doing. That's the first thing they do, Google. Okay. I do want to say there's a couple things, and I think this is an important role for us that are providers and work with sickle cell patients. We need to educate our patients about how to use the internet properly. These are the critical questions. There's some wonderful tools out there. There's one called Trust It or Trash It that you can use, but basically what that tool is asking these questions. Who said it? Where did the facts come from? Who paid for it? When did they say it? And how did they know? All right? We can teach our patients how to look at an internet website and look at these questions. I've just dealt with my husband with a particular issue with doctor ordered this medicine, didn't really go over it, and so he wouldn't take it. So I actually got him into another doctor who did a much better job, but to help him understand why he needs to take this medicine. Everything that I went on the internet went straight to the drug company that made the drug. Everything. And I'm sitting here going, I don't want to know what the drug company says. It's all going to be good. So I had to, and I'm an educated person who uses the internet. I had to really search to find the national drug, the FDA information that came out with the drug. And then, of course, it was way over my head. But I had to plow through it to really figure out, okay, why is he ordering this drug? Why is he ordering it from my husband? And then try to explain that to him. That was interesting. But we can help our patients use the internet because they're going to do it anyway. So why don't we help them do it great? So that's something we could do more of, maybe develop some guidelines or really help do some stuff about how to really judge some of that. So factors that influence patient education. How about my little man here? Look at all these things. We've been talking about them all day long, haven't we? All the different things that influence how we get educated about our health information. So I know my time's just flying. Okay. Patient education, just a few really specific things I wanted to share. In that patient education, we should have some goals. And you know what? We should have those goals that are driven by the patient. Now, sometimes we got to negotiate that, right? Because our patient, we may need to teach them about their medication, and they've got to have that information, but they may not really give a hang about that. But we have to negotiate what it is they really do need to know. So goals should be shared. And I think, have you all heard about SMART objectives? Yes, good. So they need to be specific, measurable, or otherwise observable. You need to be action-oriented, achievable, and realistic. Oh, that can be a good one. And some time frame. And there's another slide where we talk about, this is very educational based, excuse me, because I did teach for 16 years, Bloom's taxonomy, but it's important. And we want to be able to start with the easy stuff and work up. So recall, just learning, you know how we used to learn the math tables? You just have to kind of learn that, okay, and be able to recall it. And then as you move up to application and analysis, and from what I'm observing from many of you guys through this training, you're moving up that taxonomy. You're really trying to take in information, and you're trying, I can see it in your faces, you're trying to apply that, and you're thinking about, well, when I get back home, I could use that information that I got in that conference. Maybe we can do this or that, okay? And that's wonderful. That means that we are all doing what we should be doing. All right, I'm just going to walk through this. Oh, there's a handout. Yeah, I believe it's in all of yours. Forgot now. On how to write SMART objectives. And so, being at our time, we'll do very quick here. Calvin Jackson is a 21-year-old male who's recently transitioned from pediatric to sickle cell disease adult services. Sound familiar? He has been doing well with only 2 hospitalizations in the last year. He recently started a new job at Walmart, working the floor, which entails some stocking and checking out customers. He is on his feet his entire 6-hour shift. The nurse practitioner is concerned he's not maintaining good hydration, especially on these above 90-degree days here in Richmond, you know. She asked the CHW to teach, she asked the CHW to teach, and I'm not saying that this is our nurse practitioner, to teach Calvin about hydration for patients with sickle cell disease. What is going to be your next step? You're the CHW now, and you've been tasked to teach Calvin about hydration. What's going to... Thank you. Yes. There's so many factors here, but the first thing, we got to figure out where Calvin is on this. If he's not interested, remember the health belief model? We may have to go around the circuit a little bit. We got to find out what Calvin's interested in, and then we can maybe work from there. And we can use tools like iMessages, open-ended questions, motivational interviewing, right? All those tools we've been talking about. What?
So I love motivational.
Yeah. Once you get comfortable with it, it's good. Objectives should be long-term and short-term. There's one mnemonic that I've used some over the years. I kind of like it because it says, tune in, listen. Have we not talked about that today a lot? Listen, 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 okay? Edit information, act, and when I say act, we use all our opportunities whenever we get a chance. Just because I'm running to the patient in the hallway or something and there's something coming up, you can use an opportunity to teach, all right? Clarify, seek feedback, and I love the one, honor. Build on the patient's experience and knowledge. Build on what they already know. And I'm hoping that a lot of what we've done in this conference was building on what you know, because I honor you, I respect you, and that's what, to me, is a healthy learning environment. Teaching methods, we all know this. We got to know about age, gender, like we said, the generation, disabilities, educational level, knowledge of the subject. And then teaching methods in today's world, you have got to go audiovisual. I understand that in some of our Gen Zs and our Generation X and on, it's all about YouTube, and that's documented. The way that our young people are getting information is through YouTube and not newspapers. So if it's not on YouTube, it doesn't exist. All right? So we need to be aware of that. Pamphlets, we need to be careful. Demonstrations. And audiovisuals, as I said, use freely, but scrutinize for appropriateness. Know what is already out there. If you're teaching, I would say you all need to become expert on what's out there on the internet about sickle cell. You need to know who's writing it, where it is, and what they're saying. Because if you don't know that and you're trying to teach about it, you're going to have a patient sitting there that, well, that person doesn't know what they're doing because I read on the internet just last week that blah, 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 blah. So you got to do your homework. I would never in a million years walk in a room of folks that I'm supposed to teach them something about sickle cell without spending some significant time on the internet learning what's out there. Because you need to be ready. And how many of you have tried to do that? Some of you, I bet you've done some of it. Okay. But that's your task. Get out there. See what's out there. And then printed materials. This is just some guidelines that's come out of what's called Plain Talk. It's from the Teach Back movement. And we're going to talk a little bit more about Teach Back tomorrow when we talk about evaluation. But for people that are not here tomorrow, I wanted to make sure we included that. It's using active voice, personalized, avoiding slang jargon, plain language. Hematology. What the heck is that? You know, they probably think more of the blood doctor. Okay? 12 font. And some fonts are terrible to read. Stay away from them. What is it, Arial? It's terrible. New Times Roman is supposedly one of the best. 12 font. Plenty of white space. These are basics, and being in health department and working with that, we did a lot of that. Plain talk. Do not assume anything. Use your motivational interviewing and your open-ended questions to find out what is there. Demonstrations are wonderful. As y'all have found out here, we've had a couple of really fun ones. The plate activity, the fruit activity. All right. Methods, we're not going to, y'all know to do this. Simulations, audios, classroom, internet searches, social media, blogs, all that good stuff. Yes, ma'am.
Well, I have a question, and I've kind of just I've been struggling with this for actually a number of years, and that is we encourage plain talk. When we are writing materials or creating materials, it's important to speak to people at their health literacy or their comprehension level, all of that. But what's not happening is that the medical community, medical industries, everything else is not doing the same. So are we helping or are we hurting? How do we also at the same time, and I use this analogy, if our child is in 4th grade, we don't expect that teacher to keep talking to them like they're in kindergarten. At some point, you want to grow their vocabulary. And I'm just concerned that it's not that we shouldn't focus, because we should meet them where they're at, but then how do we also introduce new things to learn and new understandings along the way?
Good point. You want to speak to that? Or you have something else? Yes.
I agree. Maybe speak plainly in the language, state what a hematologist does, and then maybe in parentheses, that would be their title, or that would be the study of this. But
Right.
like say plainly what it is, and then put the word there so they have a meaning. Well, you have them both, right?
Totally.
They don't do the both.
Right.
Remove the technical
Completely, and
No.
dumb the language. Well, I don't want to say dumb the language down, yeah.
No.
But yeah.
Right. I agree that we have to do things to step people's knowledge up. We don't just ignore all of this medical terminology, but we need to help educate them what it is and how to use this terminology appropriately. Dr. Smith.
an example of this is hemoglobin electrophoresis.
Oh, yeah.
Okay, so every year we do a radio program to advertise sickle cell awareness, and we are advertising a particular fundraiser. It's a motorcycle ride. And every year, that's my opportunity to do public health education. It's on all the Radio 1 radio stations. It's very cool. All the Radio 1 radio stations carry this. So I know I'm reaching a lot of folks. I picked one concept that I'm trying to get out there. Mm-hmm. Until recently, the one concept was get yourself tested so that you know whether you have sickle cell trait or sickle cell disease. And so the technique that I used was repetition. So everybody in the studio with me, all the people who are being interviewed besides me, say it with me. So I say, everybody say hemoglobin electrophoresis.
Hemoglobin electrophoresis.
Hemoglobin electrophoresis.
Hemoglobin electrophoresis.
You get the point. So everybody needs to get a
Hemoglobin electrophoresis.
done so that you know whether you have sickle cell disease.
Right. And I think that's a challenge for us, though. I think you bring up good points. I did something with my students when I was at Longwood a couple years ago teaching community health. And I told them, they were all rotating around and going to the health departments. I said, bring in whatever patient education materials you find. And they did. And I had a class, and they brought it. And then I took some information about how to assess, and I used those criteria, plain language and all that. And I had them work in little groups. They had a lot of fun, score these. Tell me, are these good, bad, terrible, whatever. Out of probably 35 brochures that were found in my own health departments, all right, and a couple of doctor's offices, there was maybe 2 that met the criteria. They were terrible. They were from drug companies. They were from birth control companies. They were from local groups that were very politically driven. I mean, it was like Planned Parenthood. I mean, they all kind of went, oh! I said, they shouldn't even be there. Shouldn't be there. But that doesn't mean we have our work cut out for us. Yes, ma'am.
Well, I would say this would be a great chance to include the CBOs to where there could be a support group held for the parent or even the teens to where a nurse navigator or a patient navigator could go out and educate them on health literacy, on what different medical terminology is.
Yeah. Totally. Wonderful, wonderful idea. And something we did when I was working with our family planning program, we were required by the feds, which was good. We had to have a patient education committee, and it had to be made up of 60% consumers. In other words, the folks that were using the services. What a thought. And they helped us develop the brochures and the information that we used in our family planning clinics. That's how it should be done. You bring the people that are there to the table, and they should be your major drivers because they know what this stuff means to them and their families. I do want, because our time is just running away, but I love it. I love this discussion. Oh, you want it? Come on.
I'll be quick. One thing that I did notice a lot with working with families, and especially with our transition age kids too, is just like being able to pronounce what type of sickle cell disease they have.
Yes.
Sickle beta thalassemia puzzles everyone. So, I mean, we even had like a first steps little luncheon with a few of our families that have children that are 0 to 3, and it's not that the parents don't know what type, they just can't pronounce it. And so again, like you were saying, the repetition of saying, this is what it is, and I'm going to have you say it, and I'm going to have the child say it, and we're going to say it until, we're tired of saying it, so that...
Yeah.
And the way I know that I was having an effect, the disc jockey who was running the show, remember from the year, she said, I'm going to try to get this right, Dr. Smith. It's what? That's a hemoglobin
Electro.
Yeah. That was a year ago.
Yeah.
So I know that works.
Okay, I don't know, have any of you heard or had any kind of seminar training on social marketing? Good. Nobody else? I think this is something, and I throw it in here, but this is something that if we were doing this conference again, I think I would want to have a whole session on social marketing. In public health, this became very popular in the 90s, and there were several projects, and CDC has done a fantastic job. And in fact, one of the lady, what's her name, Dr. Kennedy, that was at VCU, that's how I got to know her. I think she's retired and whatever. But anyway, we worked together on a couple of grants and did some stuff, and it was really eye-opening to me. And we just won't go into detail, but it's using social marketing concepts, which come from the marketing world. You know how Coca-Cola gets you to drink that Coca-Cola, right? You know how the NFL gets you to go drink beer because it's all affiliated with the hunky guys and all that good stuff, you know. So, but they take what advertising has used and transferred it to what we call social marketing, and it's a public health way, because most of the time public health, we're talking population health. So, like we said, like we want to get the public to use seat belts. We use social marketing concepts to get this. So, on an individual basis, it probably is not as applicable. But if you're out there doing community-based education, I would say you want to think about social marketing concepts because it will help you develop that. And so even it became old hat to me as to writing a social marketing plan. Anytime I wanted to do anything that we were out there, you know, we were trying to do stuff with preventing premature birth, okay? We wrote a whole social marketing plan of how to do that, and it went through a social marketing department. So you look at the product, the price, the place, and the promotion. And it's essentially, you look at your problem, figure out what the problem is, look at what the market research is telling you, and then for us, it's like, you know, what's going on in the world of sickle cell. Create the marketing strategy, plan your interventions. Does this not sound familiar? This is what we do, right? But we're using some social marketing things. Plan your program, your monitoring, and your evaluation, and then you go out and implement, and then you count what you did, and you find out, did you have any change in behavior? So this is just, I throw it out because I think it has some, and there's your 6 phases, and they are in your notebook, so you don't have to be writing them down. And it's all about getting populations, because didn't we say attitude change? This may be one way to help with attitude change. If you've got a culture of your hospital that you're dealing with, whether it's your referral hospital or your home base, you may have some attitude changes, and this is one way you could change an attitude, is to actually do some social marketing within your community. So I throw it out. And if we were going to, you know, do something else, or at some point we were going to meet together at another time, this could be a topic that we could explore in more detail as to how can we use this. Very much based in community health. Yes, quick.
The only thing I want to say on that is Ice Bucket Challenge.
Oh, yes. Thank you. Yes. Does everybody know what that's about? Everybody know about the Ice Bucket? Tell them real quick.
Who doesn't know about Ice Bucket Challenge?
Yeah, where they did the... Yeah, demonstrate. Good, right. And in today's world with the media and the internet and all of that, see, it's much more doable, isn't it? All right. The other thing I have to say, evaluation of whatever you're doing, however you're teaching, however you're doing your education, you've got to plan your evaluation from get-go. You plan your evaluation the first time you meet and talk about this. You do not wait until you've already done it and you go, oh, well, how are we going to know whether we were effective or not? You plan that from get-go. And that's what this whole slide is all about. You have your objectives written, your education, and your activity must be based on your objectives, and then you look for the behavior change. It's very straightforward. Methods of evaluating, everything from patient feedback to observation to skill demonstrations, questionnaires, surveys with rating scales, checklists, testing. We were talking at lunch about, you know, every hospital now, you go in for anything and you get a patient satisfaction survey, don't you? And what we were talking about, though, is some of those patient satisfaction surveys may not be particularly valid. They're very reliable, but they're not valid. They may not be getting at what you're really trying to evaluate. So, and this takes practice and skill, and this is where you have smart people like Dr. Smith and Daniel and Shirley and some of these folks have been in the business. They know how to do this. And then tomorrow, well, teach back is what we already did. Everybody knows about teach back now? Technique, ask the patient to repeat what they have heard in their own words. In the patient's own words. We already had an example of that. We don't have to do an example. But I have to get to my thought. I am going to learn to relax, even if I have to work at it 24 hours a day, 7 days a week. I thought that was cute. All right, we are down. We actually officially have another session, but we don't have a break. But we do have a chance to do some prizes. You want to do that, Shirley? We don't have an official... I'm done. I'm not done the little part about the resources, so that's what I'm trying to figure out. Yeah. Let's do a giveaway. And then I will keep that... Because we don't, see, we're already at our break. Now, I don't want to miss our break. Is it out there? Oh, yes. While we set up our wheel, who did your windshield survey? I know some people did. Okay. All right. Well, you're not going to get an A- if you didn't. We're going to do a couple of giveaways, and then we're going to address that very briefly. I'm sorry, I get caught up in this stuff. Do you not realize? Whoop, 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 whoop. Do I just click it? I'm going to learn how to do this. Here's the... Okay. You want to give away what? 4 or 5, Shirley? Because we're...
Okay.
Leela Islam? She's not here. She was... That landed on her earlier. Oh. Katie Dean? Shamika Mosley? No? All right. Probability of us. Oh, is that Shamika? Oh. Yeah, that's okay. Well, that's all right. Okay, we got it. There's only one. Kendall Moody? Kendall Moody? Not here. Roll it again. You get a choice of lots of good ones.
And the winner is?
And the winner is? Carolyn Mertz. She left. See what you get for leaving?
3, 2,
1. Call it.
Esoterica Berry.
Oh, Esoterica? She left? Yeah. I've only got one out of this. I'm going to wait and do this again. Atrisha McCoy. I thought she was here. Where? Oh, okay. Yes, I thought, where did you go? I just saw you. Brenda Merriweather? Ah! Good. I'm going to give 4, and then we'll... So is break not out there? Is break out? We're okay? All right.
He's right here.
It's the same. We do got... Oh, sure.
David Payne.
Yay, David. Yeah. Oh, no, that's all right. We'll do one more. We got a lot of orange ones. But the colors don't have any meaning. Alicia, is it Lisa? Lizer? Oh, good. All right.
Yeah, I got it.
Okay. Is our staff around? We need to punch, I think, again, don't we? So can they come around, my punching staff? And I'll go on and do our last little bit here on, yeah.
How many more sessions?
This is this, and then we do our panel, our stigma panel. So we're down to the,
So
okay.
this is the one?
Mm-hmm. Yep, put it on, yeah. Okay, so our staff will be around to help punch people in. And community assessment is one of those things that I've spent my public health life doing, all right? When I say community assessment, what in the world do I mean? What do we mean by community assessment? I hate to tell you, but some of you community health workers may be involved in doing this. Yes, ma'am. We got to... What do you think?
What's the question again?
What does community assessment mean to you?
It's just, I guess, getting the temperature of the needs of the people within your community.
Exactly. Exactly. Officially, in the public health world, we talk about community needs assessment. That has real meaning for us. That means we go out and assess through many ways a community. And we look at everything we can find. All right? We look at the primary data, which maybe we go out and do surveys, we go out and do key informant interviews, we do all kinds of stuff. Secondary, we use every data system, every data collection system we can find, and we look at data, all right? As community health workers, oh, Justin, he left me, that's all right. Okay. In maternal child, one of the things I had to do every single year was we had to do our community needs assessment on maternal child health in order to get our Title V money from the feds. Every 5 years we had to do a thorough, complete, but every year we had to go fill in the gaps for everything else we had done. But every 5 years we did the big one that determined our funding, okay? So it was all about how many children and how many children with disabilities and how many pregnancies and all of that. So I was intimately involved in that. And so if you're looking at other areas like the chronic disease grants from CDC, they have to do the same thing. It's a huge undertaking, and you plan for it all year. As soon as you finish one, then you start planning for the next one. All right, when I say primary data sources, this is where you go do focus groups, you do direct interaction with the community, and guess what? You don't leave out your elected officials. You go find out what they're doing, where they're coming from. Hospitals in today's world have to do needs assessment on annual reports. Any hospitals that get any federal dollars have to do these. Are we all aware of that? And those reports should be available to you. And they have done the same thing that the health department does for the state. They should do their catchment area, and that information ought to be available to you. So things like what their discharge rates look like, what their catchment areas is, how many patients they've seen, what the complexion of those patients, and I don't mean skin color, but that is part of it. In other words, they've served this many different races and creeds, I mean all of that, okay? So those things should be available to you. You may have to search them out, All right. Secondary data sources are all those things that are available to you that are databases that most of the time you can get a lot of this information. There's a lot of other databases that you can't always get. Like, I don't think, is HEDIS data available? I don't think it's not public. That's what I thought. There's a lot of like hospital data, like what we call the discharge data. They do reports, and you can get those reports that are published, but if you want special runs, you got to go make a request, and you pay money, okay? But things like census data, remember we're getting ready to do a census. That's very important so that we have a feel for who's living in our country. And you remember the whole debacle about whether or not you ought to be a citizen or not and all that. Well, right now, the purpose of that is to figure out who's living there, not how many citizens we have living in Bedford County. We want to know who's living in Bedford County. Okay, from a public health perspective, I know I'm biased because it's a public health thing, all right? National and state mortality data, and that's how we get some of our mortality data regarding sickle cell. It's from the mortality. We don't have a sickle cell database registry, right? But we can get some of that data through hospitals, through Medicaid and insurance companies, and from the mortality data. So if I want to know how many heart attack patients were in my county, I can actually get some of that information. I want to know how many birth defects occurred in my county. I can get that information. It's collected by our government, and it's available to all of us. Have any of you heard about the behavioral risk factor surveillance system? Yeah, okay. That's through CDC. You go on their website, and you can get all kinds of good information about, how many people in certain areas smoke. Now, the problem is it's not broken down by city or county necessarily, and it can vary. In Virginia, we can get our health district level data, but I can't necessarily find out about Bedford County or Campbell County, okay? I can find out about Central Virginia Health District. All right, so, but that data is available. Hospital needs assessment, I mentioned, insurance data, and other hospital data. And then there's probably a lot more out there. I just listed what I think are the pretty reasonable ones that if you're doing something where you're trying to work with legislators and all of that, you need to dabble into looking up some of these data sources. And here again, it would be something that we could be providing some consultation on about how do you go about collecting this. Another public health is what's called mobilizing for action through planning and partnerships, better known as MAP. And we went through this in Virginia a few years ago, and our local health districts still do this. It's actually just a tool, it's a mechanism of what you collect. It's very, very intense. It takes about a year or so to do it. It's a whole plan of how to go about doing a community needs assessment. The National Association of County and City Health Officials has a wonderful website, and they really can do a walkthrough exactly what you do for that. It's not sickle cell specific though, but this is just if you're looking at your general area. The windshield survey. All right, I did want to ask. I think we're going to skip doing the small group, but just as a moment in that it's a public health tool. That's all it is. It is nothing fancy. It's a way to look at the community through direct observation. You could be learning, you could be living in a community, but unless you went out looking at certain things, you may have just glossed right over it. So if some of you are willing, if you did yours, what was kind of your take on doing the windshield survey? Did you find out anything that surprised you? You did. What did you find out?
I found out that certain areas of the neighborhood that I was surveying that the water quality was poor.
Okay.
I found out that there were dilapidated properties, illegal dumping. They didn't necessarily have right in that perimeter fire stations or police stations. They were in that city, but not close to those neighborhoods. Mm-hmm. Yeah, I thought that was very interesting. Mm-hmm. And then as far as the recreation centers and things, they were further away from the neighborhood that I was surveying. And also, I found out that they did pledge to put about $3.7 million into revitalizing that area. But
You're not seeing that.
well, I did see some of it. Yes, I saw the paving of the roads, and I did see that they had started painting some of the buildings. But yeah, I saw that they had began to make changes. Mm-hmm.
Anybody else would like to share? Anybody else would like to share that did their windshield? I've done this with students when I was teaching public health. It's very insightful because you have to realize I had some students a lot of times came from, white middle class, down in Longwood, not a whole lot of people of color. There's a whole neighborhood or two, and they'd have to go out and do stuff. It was very enlightening to them because they never realized, they were used to their worlds from Northern Virginia and Richmond and stuff, and it's like, oh, okay. I've used it also in working with public health folks, and there was a grant we did, and we actually took our worker bees, and these were our community health workers that were working with high-risk OB patients. And we took them out, and they went out one day and went around the neighborhoods and did the windshield survey and came back, and we had a big discussion about it. They found all kinds of interesting, and they were from these neighborhoods, and they had never stopped to think, well, what if there was a fire? Gee whiz, that fire station is pretty far away from the project, So it's just a tool that we wanted to introduce you to, thinking that at some point you could use it if you're doing something with your community. And I think, how did it go? What surprised you? What didn't surprise you? One more thing is, are y'all aware of the 211 information referral line? Good, wonderful, because I know at one point when I was working early with us, people didn't know about it. So I plucked the ones from the states that I knew that were represented here as best that I could find. So all of you have a state place to go. The United Way is a very popular group that seems to house this, but this is a federally supported program that comes out of the government and that comes to the states, and then the states award whatever contract. In Virginia, we use a lot of United Way. A couple of other states did too. But it's both web-based and phone-based. So people can call, and it's all kinds of human services. Everything from plumbing needs to water to whatever. So it's something that you could use with your patients, or you could do it even with the patient. It's also internet-based. So you don't have to, but of course the benefit of the phone base is that you have a real person talking to you. All right? And so somebody can really maybe assess some things. Yes, ma'am?
Sometimes you have to be careful because sometimes there's a different phone number for landline than there is for cell phones.
Yes, thank you. Did y'all hear that? There is some variation on landline. Of course, we have that issue all over our country right now, isn't it? Is that landline versus cell phone. We have that issue with some of our data collection systems. They're not using cell phones. Well, how many people have landlines these days? So that's a real issue on some of the CDC collection systems, and how valid are they. Okay, I'm out of time. Where are we? Okay, I think we have a break. Hold on a minute. Any questions, comments you want to make right? You're probably exhausted.
So I need to tell you all something that just came to my attention. Those of you who have received gift cards in your packets, apparently there was an expiration on those that we were not told about. So if you give us a day, we are going to go ahead and call the credit union and get those reactivated. I don't know what they did, but anyway, why not? So just so you know, they will be good for the amount that's on there, but at least maybe give us till like Monday to use them. Something happened with what they did when they they gave them to us. So they're not fraudulent. We just don't know what happened. And I didn't know that until I guess somebody here went and told one of the staff. So apologies for that, but we will get those activated, okay?
We ready for break?
We're ready for break, then we're going to come back for our last session.
Okay, sounds good. We're going to take about, 10 minutes or so before you get started? Or just get your stuff and we'll get rolling. We have a panel coming up. I think it's going to be interesting. Thank you, all of you. Appreciate your attention.